Today's topic is defining medications for patients with kidney failure. And what I'm going to try to do, I hope it's not too basic for some of you, because I know lots of people already have a lot of information about kidney disease and are been living with kidney failure for some time. But I'm trying to keep it very simple and well, hopefully not too simple for those who are watching, and hopefully everybody will be able to follow. So I'm going to try to explain why medications are required at all, outline the main groups of the drugs which are being prescribed, and also to explain the roles of the drugs prescribed. So remember, it's a very um, general general topic, a general discussion, and but hopefully you will gain from what we've got to say. So as usual, I just want to go back to cover some basic concepts around medication and basically how are medications prescribed. As you know, when you get a prescription, it might say whatever the medication is, PO, or it might say IM, or it might say SC. And so PO or oral means that the medication is given by mouth. IM is intramuscular. SC is usually subcutaneous, and those medications mean that it's injected. And as the name implies, IM, intramuscular, is into the muscle, subcutaneous, just underneath the tissue. And medications may also be given intravenously. Now, you probably, as patients, might not see this instruction being given, but we would usually, as doctors, write it up saying IV, and that's usually into the veins and given via a drip. Topical medications are those medications which are rubbed onto the surface. And so this would be like your fusidine creams and that sort of thing. I have not included sublingual on here. It's not very common, but some people may have medication written as SL, which is sublingual, given under the tongue. So just so we have a general understanding when you see a prescription, what everything there stands for. And to just review the basic anatomy, as I said, I know we've got people of all different levels watching, so I just want to make it clear to everyone what we're talking about and where the organs are. So we have two kidneys usually, that's in normal anatomy. And if we were to place our hands in our sides with the thumbs at the front, where our fingers are reaching at the back on the left and the right side, is where your kidneys would sit. So sort of posturally in the abdomen, sitting towards the back. As I said, there are usually two of them, but some people may have been born with one. They're usually one on either side of the abdomen, but again, they may be on the same side. They may not be situated where I have told you to place your fingers. They may be located lower down, and obviously and different arrangements, but this is the basic anatomy of what we consider as normal. So most people will start with this. You have two kidneys, and the kidneys have ureters, and the ureters is where the urine passes out and is sent into the bladder. So this is where it is, the two ureters here on either side and going into the bladder and then being urinated. So here is a cross section of a kidney. So yes, it looks very simple looking at the two from the outside, but if we were to take a cross section, we see how complex it is. And so I've done this, not that you need to learn all these names for all these structures, but just to give you an idea of just how complex a structure the kidney actually is. So if you were to take a cross section, you'd see it has several different layers. You've got your renal cortex here. You have the renal papillae, renal pyramids, columns. There's a fibrous capsule covering everything. And if you were to then even do a further cross section of here, taking out even a cross section here, you'll see that it's even more complex. Then you start to see tubules and glomeruli, and it gets, as I said, it is quite, even though it looks quite basic from the outside, it's quite a complex organ and a very important organ. So again, this just goes to show just how complex it is. You have the kidney sitting in the middle, and this slide just shows how it interrelates with several organs in the body. So it has a relationship with the lungs, establishing what we call acid-base balance or homeostasis. Again, I try to stay away from big words, but this basically means it keeps the pH in a balance. So homeostasis is just keeping things the same and um, interacts with your brain, regulating your thirst and your breathing, um, using along with hormones that are secreted, interacting with the heart has an impact on your blood pressure, your heart rhythm, the adrenal glands, your bones have an impact on your calcium and your phosphate metabolism. The muscles similarly interacts with your gut. It's very important to interact with your bowels to get that vitamin D absorption and also the calcium metabolism. Interacts with your liver and is very essential in the production of red blood cells. So, as I said, you don't have to remember all these things, but this is really just to give you an idea of just how important those two little organs are. So, to explain the roles of the kidney. So I've shown you that it interacts with several different organs, etc. But I've then just taken out and just put it in words so you can see it's involved in the removal of metabolic waste. That is after the body has broken down several, had several chemical reactions in the body, and we need to excrete some of that waste. That is what the kidney is for. It is involved in the regulation of water concentration, the regulation of electrolytes in the body. We know we always talk about sodium and potassium, and that's why those are electrolytes. Excretion of drugs. So when we ingest medication, it then has to be excreted, and some of it is excreted in the liver and excreted out in the stools. Some of it is excreted through the kidneys into the urine. The kidneys also assist with calcium metabolism, and we'll talk a bit, of course, we'll talk a little bit more about that as well, because that is a very big part of your medication load. It assists with building hemoglobin, as I mentioned in this slide before. And as I said, it interacts with the heart and is therefore, on its own, it helps to regulate blood pressure, but also in conjunction with the heart, it's quite important in regulating the blood pressure. So as you can imagine, we have so many things that we need to supplement if the kidney is not working. We have so many of those roles that we need to fill in to make sure your body is working effectively. And unfortunately, we don't yet have a magic pill. So that's why we seem to have, there's, this vast array of medications that we are given to you on a daily basis, because we don't yet have a super pill. So this is why we have to break it down. Okay. So let's start now with one of the main roles, which is regulation of blood pressure. As I said, it's the kidney itself has a regulatory role, but in conjunction with the heart, it also plays a role. And again, I know we've got people for different levels, so I hope I'm not being too basic, but I just wanted to explain what blood pressure was. So blood pressure is actually just the pressure of the blood pushing against the walls of your arteries. And if you think of this like plumbing in a house, you need pressure to go and supply all your rooms. You need a certain amount of pressure in the body for the blood to go and perfuse all your organs. And that's why it's necessary to have a blood pressure. What you don't want is to have an extremely high blood pressure, because then, just like if you have, again, a pressure in a pipe at home that is too much, it can burst, rupture, and then you have damage to that area. Same thing with blood pressure. So an elevated blood pressure is referred to as hypertension. And so this, if we continue to have such high pressures, you can then have injury to vital organs. So you can have injury to your heart, to your brain, to your eyes. I'm sure lots of people would be familiar with us saying that, hypertension being a silent killer. Some people feel, or most people feel very well, even though they've got very high blood pressures. But unfortunately, that damage, that faucet that you didn't know was leaking is damage, is leaking out slowly and damaging all of these structures around it. Same thing with the blood pressure. So you may not feel unwell, but the damage is being done. And that's why we are so um, careful about trying to control blood pressure for patients. The management of hypertension is multifold. So we emphasize dietary changes, especially low salt diets. And this is the standard. We recommend this for everyone. Reduce your salt in your diet because this helps to reduce the hypertension. We're very salt sensitive, especially as Black people, we're very salt sensitive. So dietary changes are suggested. Smoking cessation, just stop. So there's no reducing. We really just advocate for no smoking at all because this does impact on your blood pressure management. Alcohol restriction. So again, to a minimum. We encourage everyone to exercise. And so the dietary changes, the smoking cessation, the alcohol restriction are pretty much the basic recommendations for any non-communicable disease. And so those are the things we start off with, trying to get everyone to do these things. Unfortunately, as you know, as patients with kidney disease, you may be a bit fatigued. It may be quite difficult for you to get in the quantity of exercise that we recommend for various reasons. And so most people will require medication to manage their blood pressure. And I also want you to recognize that not just patients with kidney complications or kidney disease will require medication to manage their blood pressure. Most patients will require medication, and most patients, regardless of why they have hypertensive, will require more than one medication to manage their blood pressure. So the management of the blood pressure is done using medication referred to as antihypertensives. So which is again self-explanatory. Hypertensive is if your blood pressure is high. Antihypertensive, we're trying to combat the hypertension. So there are several different classes of drugs used to control your blood pressure. And in the medical world, what they try to do is to have similar names for similar groups so that most people will know what group of medication is being prescribed. So you have calcium channel blockers. Those are really things like your amlodipine, nifedipine, as I said, similar names, all ending in INE. The beta blockers like carvedilol, bisoprolol, atenolol, again, ending in LOL. The angiotensin receptor blockers or medications like your valsartan or trade name Diovan, your candesartan, your losartan, again, similar ending, ARTAN. The ACE inhibitors are medications like the ramipril and the lisinopril. Again, you hear the similar endings. Those four groups of the antihypertensives that I've mentioned so far are probably the most common ones that you may be started on. And the choice of those medications is decided on based on, well, why we're starting you on, on the antihypertensive medication. So it may be that you have another chronic illness or another complaint that we're also trying to manage. So that may also affect what we start you off on in terms of medications. For example, patients who may not yet be on dialysis, but will have may be spilling a lot of protein in their urine. So they heard the doctors say, well, you got proteinuria, or you get a urine sent off the lab to measure how much protein you have, or your protein creatinine ratio you hear is elevated, or they dip the stick in the office and they see a lot of protein when they do a urine dipstick in office. So those people might be started on an ARB, like a valsartan or candesartan, because that is supposed to reduce the protein spill in the kidney. So that's again, so you might be started on that as opposed to starting on a calcium channel blocker or a beta blocker. Patients who have cardiac failure or have had a myocardial infarction may be placed on a beta blocker, and they may be placed on a beta blocker even if you have already been on one of the others, because they are thought to have a protective effect as well. The What you may also note about your beta blockers is that people who have been on medication for a long time, and certainly if there are any medical personnel here, health professionals, will remember that atenolol sort of was an older beta blocker that people used to be on atenolol a lot, but we found now there are lots of beta receptors in the body. So the beta receptors are channels in the body in various organs where the beta blockers act. And it's not just located in the heart. But what we found is that there are specific beta blockers to various organs. So your new beta blockers, and so medicine is continuously evolving. So the newer beta blockers like your bisoprolol and your carvedilol are what we call beta selective. So they will go and act on the beta receptors for the heart and have more of an impact on the heart rather than going and acting in other beta receptors around the body, especially the lungs, which was a big problem with the generalized beta blockers. People with asthma and so on would have issues because they would be affected, have pulmonary symptoms because the beta blockers are also going and acting there. But as I said, now we have newer agents. So you'd find that you were being switched off from your atenolol or switched from the bisoprolol to go on to carvedilol. And it may seem like it's just a small dose of the carvedilol that you may be placed on, but it's shown to have an impact on your cardiac function. So again, it might seem like we're just picking medications, but there's a lot of thought process as to which medications we're choosing and why. The medications which I have not really talked about was your alpha blockers, like your tirazosin, vasodilators, like your hydralazine and minoxidil. We have quite a few patients on these, but these medications tend to be chosen when we have almost maximized the other four groups that I've told. There are a lot more side effects. They tend to be stronger. Patients do find that they can feel when they've taken the effects of when they've taken these medications, and we use them if for patients who have resistant. We've been trying to reduce their medications with other meds and the other groups that we mentioned. We've not had a response, so we have to go to something else. And the whole way we approach the medication is that we are trying to control the hypertension with as few drugs as possible and with as few adverse reactions as possible. So what we found in the past is things like ACE inhibitors sometimes gave people a cough, this dry cough that just didn't seem to settle with simple cough medicines, etc. The beta blockers also produce a cough. As I said, that's because they were not that selective, but that's less of an issue in recent times. And things like the calcium channels that you're on amlodipine and so on, some people complain that they caused ankle swelling. Most of the newer agents are very well tolerated. And of course, I mean, there's always adverse reactions like nausea, vomiting, just don't feel very well, feel too lightheaded. Those can happen with any medication that you take. But I'm just thinking these are the common things that people would report, certainly in our setting. And for patients who are prescribed antihypertensives, the main thing is to take them as prescribed. That is the best recommendation we can give. Patients may be on a twice daily dosing, they may be on once daily, and whatever your medication is, you should be taking it as prescribed. It is thought as well that there is benefit to taking at least one of your hypertensive medications at night. And not to get too technical again, but at night, patients who have been found to maintain a high blood pressure during the night seem to have more adverse outcomes. So it is thought if you take at least one antihypertensive medication at night, that helps to reduce that nighttime blood pressure, which you would expect in a normal person. So for patients who do not have hypertension, we expect that when you're asleep, that your blood pressure is reduced. Or dips in the night. And so people who medicate, who are hypertensive and don't have, and are non-dippers, as that is referred to, are advised to take at least one antihypertensive at night so that you then go back into that normal state, which you would expect for persons. And for patients who are already on dialysis, we still expect you to take your blood pressure medication, all of your doses at all times as prescribed, unless you are coming into that first shift. I know we have patients from other outside of Barbados here, but certainly for our unit, we start very early. So sometimes by 4 or 5 o'clock in the morning, patients are receiving dialysis, and we don't expect that those first, what we call the first shift patients, will take that first early morning medication before coming onto the unit, because we don't want to see that big drop in your blood pressure on when you're actually being dialyzed. But otherwise, you should be, so if you're coming onto the shift, say 10 o'clock, 2 o'clock, later in the evening, you should have taken your medications up until that point. So that's just some general advice for the antihypertensive medications. There are other cardiovascular medications which you may see on in your prescription being dispensed, and that would include medications like nitrates, and this would normally be given to patients who have sometimes complain of things like angina, because of angina is occurring, get this chest pain because of constriction in the arteries, and the nitrates helps to dilate the blood vessels and easier for the blood to flow through the heart. So what we also need to remember is that because you are a patient who has kidney complications, it does not mean, unfortunately, that you can't have complications occurring elsewhere. So because you have kidney problems does not mean that you cannot have complications with your heart, that you cannot have complications with your brain, that you cannot have complications with your eyes. Actually, it probably means that you are having complications with all those other places. So this is why we want to give you other medications to help to reduce your risk of having any more adverse outcomes with these other organs as well, and trying to keep you as well as we can. So that some of you may also be prescribed statins. And again, a statin, there are a group of medications that decrease your cholesterol. So remember, just like how we had the blood pressure medications in groups ending with similar endings, the statins are a group for decreasing cholesterol. So things like atorvastatin, simvastatin, pravastatin, those are medications, and the trade names that you guys might know is like Atarac or Crestor. There's also a combination of medications like Vytorin and different newer generation statins that might not have the ending of statin, but are there to do the same thing, which is to decrease your cholesterol as well, because cholesterol, in addition to hypertension, is seen as another additive risk for your risk of having a heart attack or stroke. And again, even though we're managing the kidneys, we don't want you to go on to have these effects with the other organs, these adverse outcomes to the other organs. Another group in the cardiovascular arsenal, as it were, is medications which reduce clotting. This would include medications like aspirin. Most people are familiar with aspirin. It's an over-the-counter medication, but it is very beneficial and very powerful. So even though it is over-the-counter, we should not, let's remember there is a medication as well, and does come with adverse effects which we need to monitor. So aspirin is sometimes prescribed to reduce clotting, as clopidogrel. Certainly, patients who have had things like a myocardial infarction may recall that they didn't commence on aspirin or commence on clopidogrel, or both. Sometimes they're both added, and at the discretion of the cardiologist will decide that. And that is usually a daily medication. Warfarin is a medication which is prescribed to help to reduce clots as well. So these would usually be given in patients who had a history of clotting. So you may have had a deep vein thrombosis, or if you're already a patient on dialysis and you have a vascular and your vascular access you've had a history of clotting there, you may have been placed on warfarin to help keep the blood thin, as we would say, to so that that clotting does not recur. Because as you know, if you do get clots and it does become blocked, then you are at risk of having no access and therefore cannot continue your dialysis at that time. So, and the warfarin is a lot more difficult to manage because you have to do frequent blood investigations to make sure that something called your INR is in the range that we want, so that you can manage the reduce the risk of clotting without encountering the risk of bleeding. Because like anything, if you know it's too far east is west, we don't want to give you too many, have a too high dose, and then instead of clotting, you're bleeding. So that's one of the complications too of the anticoagulant medications. Obviously, if they're giving you something to stop the clotting, then you're at risk of having bleeding. And so that again needs to be monitored. Subcutaneous medications, which do the same thing as their warfarin, your clopidogrel, aspirin, in terms of reducing clots, and medications like your Plexane and your heparin. Again, patients who have had things like pulmonary embolisms or deep vein thrombosis in the past may have remembered that they were prescribed Plexane, and that is medication which is given, as I said, subcutaneously, and for the same, and to do the same, it's had the same effect, but it's a subcutaneous medication, usually a once daily maintenance. It may start off as more than one dosing initially, but it's usually for maintenance dose, it's usually once a day. For patients who have been admitted to hospital for long periods of time, even if they are not on dialysis, but just any patient who's been admitted for long periods of time where we know you're going to be immobile, you may have been prescribed heparin. And certainly patients who are on dialysis will know that there is heparin usually used within the dialysis circuit to, again, for the same reason, to stop clotting within the circuit, because we want you to be able to have your dialysis where you are, your dialysis is not clotting in, and you can have your blood returned safely. So you have all your blood being returned rather than clotting, and then we end up with blood being remaining in the circuit. So those are medications which help to reduce the clotting. And so that is medications from your, so that's the cardiovascular medications that you may be prescribed, or you'll see on your prescription, whether it's your dialysis prescription or prescriptions that you had in hospital. And another medication which is not, well, not directly a cardiovascular medication, but also impacts your blood pressure, is Lasix, which is used to help with the water regulation, the water concentration that I mentioned, which happens in the kidney. And Lasix, or the generic name is furosemide, is a medication. It's a diuretic, which means it makes you pass water more frequently. So you can reduce, especially for the patients who are not yet on dialysis, but may recognize that they have a lot of swelling in their feet and so on due to that excessive water buildup, fluid buildup, because the kidney is not producing as much urine as we would like. We give you Lasix to help to push that urine out. So again, using the whole pipes in your house analogy, if you can imagine, if you were to go and you have a certain pressure and you're building up in your pipes, and you go and you turn on all the pipes and the water rushes out, that pressure in the pipes is reduced. So again, if you give Lasix, it can impact your blood pressure, and actually, even though it's not given as a blood pressure medication per se, it will have the impact of lowering your blood pressure. So again, if that's something you also need to be aware of. The kidneys are key to assisting with the building of hemoglobin. A lot of so there's a hormone being produced in the kidneys called erythropoietin, and it is essential in the whole building process of your hemoglobin. And again, just to keep it basic, the hemoglobin is basically just a protein in your red blood cells. And it's usually 4 chains. Not to get bogged down again, don't worry about all the little fancy chains. It's just 4 protein chains. But if you look at the picture, you'll see that it's got some iron in there and a heme group. That's what we need to focus on. So the essential building blocks for the hemoglobin is iron. And The hemoglobin is essential to the body because that is what is there to transport the oxygen around the body. And as it transports the oxygen, as it delivers oxygen, it picks up the carbon dioxide so that that is then released as well by the lungs. And this whole pickup of oxygen and dropping off oxygen and removal of carbon dioxide is essential for maintaining the acid-base balance in cells. So again, people might, you know that the body has to operate at a certain pH level, and pH is just the acidity that is required, acidity or alkalinity that is required in the body. So not too acid, not too alkaline, and it needs to be just right. And this is, so the hemoglobin is essential for this because it transports oxygen, which is required. Patients who don't have enough hemoglobin are referred to as anemic. So a low hemoglobin level is anemia, and patients may find that they complain of being very tired. They have maybe short of breath. Patients may suffer from headaches. Again, dizziness, because remember, this hemoglobin is carrying your oxygen around. Your oxygen is required to make the body work and to produce all those constant chemical reactions in the body. So if that's not happening, patients can feel very unwell. So, as I said, because of the kidney is responsible for this function, we need to give medication sometimes to supplement what the kidney is not able to do. And so, or to boost the body because the kidney is not able to function as effectively as it is. So we need to make sure that we're giving our body the machinery to carry on. So we may give oral medication. So those would be things like your iron tablets, ferrous sulfate usually, because that's a good way the body can absorb iron. Um, the Another building block is your folic acid. Vitamin C is essential because vitamin C actually helps in the absorption of iron. So again, if you look at your prescriptions, you might see that we are prescribing iron, we are prescribing folate, we're prescribing vitamin C. And that trio is essential because that is those are some of the basic building blocks that we need to produce the hemoglobin. So that's what we give you in the oral form. And there's medications, but remember at the beginning, we talked about oral, we talked about subcutaneous or intravenous, and we have something in each category to assist with the building of the hemoglobin. So in terms of the subcutaneous medication, this may be in the form of Recormin, or Mircera. Again, my apologies for persons outside of Barbados, but I've mentioned the names of that we have here, but other names that I can recall are things like Epogen, that you may see, Ferlicit. Sometimes you may see other names for these IV and subcutaneous medications, but they all pretty much work in the same way. So your Recormin and Mircera actually go to stimulate. Remember I said that the kidney produces something called erythropoietin, which is essential to drive, is like tells your body build more hemoglobin, build more hemoglobin. And we give you the Recormin and the Mircera to help do that. But before we do that, it's no point me telling your body to build more hemoglobin. It's like I'm walking into a factory and saying, you guys need to build more cars, but I've not given you any wheels, any doors, no windows. So before we start to give you the Recormin or Mircera, we have to make sure that you actually have all of the other things required to do this production. And so patients will recall that we quite often ask you to do something called iron studies. Those are blood investigations. So we do the blood investigations first so we can see what level of iron you have. We look at something else called ferritin. We look at something else called your TIBC, various parameters. We look at your B12, which is also important in the manufacturing of the hemoglobin. We look at your B12 levels. We actually look at the same folate levels. Folate is the same thing as folic acid. So we make sure that you have all of those things there. And if everything there is fine, then we're good to go with your Recormin and Mircera to just help the production process. If, however, those things are not there, especially if you were low on iron, if you don't have enough iron, we can't tell you to make more hemoglobin because you don't have the building blocks to do it. And that's where things like Venofer comes in. Venofer is an intravenous form of the iron. So, but remember, we can give it to you orally as in the form of oral tablets. So some patients may be asked to take iron once a day. Some people may be asked to take iron twice a day. Some people may be asked to take iron 3 times a day, because and it all is dependent on where we're starting. What numbers are we seeing when we do your blood investigations? So when we do those, we know where we're starting, and when we have got your levels to a point where we are comfortable that you know how the building blocks, then we can start pushing production with your requirement and your Mircera. The requirement is usually given, can be given several times a week, and there's a big range of dose. The Mircera is usually given every 2 weeks or once a month. And again, the Venifer is given as required, again, dependent on what your levels are before we start. Adverse effects or complications, usually from the oral iron, is constipation. The requirement in Mircera, and I don't have here, but yes, your Venifer as well, can cause hypertension. So again, it's a very sort of balance. It's a balance. You're balancing all the time, because we don't want you to be anemic, but we also don't want you to have the side effect of the hypertension. For patients who have constipation, we sort of try and work with you and give you medications to help that as well. But you have to remember that, again, everyone is different, and so the approach is going to be different for different patients. But so the requirement in Mircera, while it might be causing, you have a risk of hypertension, having a low hemoglobin also puts your heart under strain as well, because your body is trying to pump around just this little bit of hemoglobin and trying to do all the jobs that the hemoglobin is supposed to do at a low level, which can make you very unwell also. So it's really just a balancing, and that's why the doctors will have a discussion with you, among themselves, to decide what we need to do. For patients who are not yet on dialysis, the requirement of Mircera, which can also be given intravenously, will probably be advised to take that subcutaneously. And the reason for that is because if we think that you are at risk of having to go on dialysis later, we want to preserve your veins. So for patients who are not yet having dialysis and therefore having a vascular access, we would advise that you take those medications subcutaneously rather than intravenously, because we don't want you to damage your veins, because we need those veins for to use for access in the future. And that is, but it can be given either way. For patients whose hemoglobin is very low and we need to move it quickly, we need to quickly get it up, you may require a blood transfusion. So yes, this is considered, it's not a medicine that we can write on a sheet and give you, but it is medication. Anytime we're giving you some of this, we can consider this as a medication. And as you know, as with a production line, things take time to build. So if I give you Recormin, Venifer, whatever I'm giving you today, I don't expect to see a change in your hemoglobin by tomorrow. I just expect that over weeks to months that I'm going to see the change. But if I need if I need to get your hemoglobin up quickly because you're so unwell, or because I'm concerned that you may become very unwell, then you'll be prescribed a blood transfusion, because that is it. You don't have to worry about working anything. It's already up, it's made. But as you know, it is not straightforward, because you need to have the right match. You need to have blood available. You need to have the access to get it. You need to make sure that when they've given you this fluid, that you don't then become overloaded and end up with other issues. Overloaded means that after the transfusion, you're short of breath and so on, because now you have too much fluid on board, because it is a liquid that we're giving. So all of those things have to be taken into consideration when we are treating patients. And you as patients need to recognize that everything comes with its risks and its benefits, but again, it's supposed to be a discussion between you and your doctors. So calcium metabolism, I mentioned that this was a big one, and because the calcium is responsible for so many functions in the body. And certainly as children growing up, you would be told, or drink your milk because you want to build strong bones and teeth. And but calcium does just more than that. It's responsible for assisting with the clotting of your blood. It helps and to receive nerve signals in the body. So patients will know sometimes if their calcium is low, they'll say, "Well, I've got tingling or I've got numbness in the fingertips," and this is because they've not got an adequate amount of calcium able to do that job, and you get those sensations. It's involved in helping them squeezing and relaxing of muscles. And so again, you might get cramping and that sort of thing if your calcium is low. It's also essential to help in the releasing of hormones and other chemicals in the body and keeping a normal heartbeat, which you mentioned, remember the first slide when I show you that the calcium and the heart, the kidneys and the heart working together as well. So obvious medications which assist with calcium metabolism is calcium. So this is given in the form of calcium tablets, usually just calcium. Um, Usually, I think the ones we have usually here are referred to as caltrate. You may have it in the form of Tums. Some patients prefer the Tums because they're more palatable. The calcium tablets tend to be quite large, and patients struggle to take them in the quantities that we prescribe. Unfortunately, those quantities are essential because of how important the calcium is. And if it's given intravenously, it's given in the form of calcium gluconate. And some patients might say, well, why not just have the IV form given all the time? But it is not something, and certainly in this part of the world where we are, and again, I know it might be different in other areas where patients are receiving medication, but we also have to err on the side of what is reasonable, what we can afford, what is available. So if we can't afford it, and if and the IV calcium is not available, we have to work with what we have. And the calcium tablets, when taken as prescribed, will work well, but it's just really to actually take them. The vitamin D is given in the form of 1 alpha, and vitamin D works in conjunction with calcium. So calcium, vitamin D, and sort of phosphorus all have this working relationship. And the vitamin D is essential in the calcium metabolism. The thing is with the vitamin D is that we give it in the form of 1 alpha because, and not the normal vitamin D3 that you will see sometimes even included in your calcium medications. Sometimes it comes as a pair. You see like calcium, caltrate, I think it's caltrate D. Sometimes it comes as, but unfortunately that vitamin D that is given with that calcium is not of much use to a patient whose kidney is not functioning well, because there is a process, a chemical reaction that is undergone in the kidney, and it's called hydroxylation, and that hydroxylation occurs at the 1 alpha point of the vitamin D. So it's 1 alpha hydroxylation is what happens in the kidney. And so even though we're taking the kidney in, we're taking the vitamin D in from to the sun, to the skin, it can go into the liver, it undergoes the hydroxylation there in the liver, but then it needs to go from the liver to the kidney to go on to this next hydroxylation, but we can't do that if our kidneys are not working as they should. And so we have to give the vitamin D in the 1 alpha form so that that vitamin D is ready to work, because it can undergo that conversion. So we give it in the converted state so that the body can move on. The 1 alpha is, so some people will know it as rocaltrol, and that's one of the names of it, but it's also available in an intravenous form, and that is called Hectorol. That again, that's what we have here, but there are other versions. But basically, so that's being given either oral or intravenously. And so calcium metabolism itself is affected by dialysis, is affected by dietary intake. As you know, most of what is happening in the body is affected by your dietary intake, and is positively related to renal function. So if your kidneys are function is decreasing, your calcium absorption is also going to decrease. As I said, calcium and phosphorus work closely together. So phosphorus is doing a similar job in terms of assisting with the formation of the bones and teeth, maintenance and repair of the cells. muscle contractions, normal heartbeat, nerve signaling. So all of those things that we mentioned for calcium, phosphorus is right there helping it along. And uh, well, everyone knows these are one of the parameters that we check as well every month to see what your levels are. So you know that we're checking your hemoglobin, we're checking your calcium, we're checking your phosphorus. And these are certainly patients who are on dialysis in our units on island. We'll be having these parameters checked every month. They may be different standards in different units. They may be different periods of checking if you're not yet to the stage where you require dialysis. But again, how frequently you're tested depends on what is going on. And we like to see trends. So we'll look and see, okay, well, this patient is managing so fine. They're doing it. They seem to be compliant with the medication. They're going, we don't maybe not need to check them this month. These are not for your dialysis patients. These are for patients not yet on dialysis. So it may be a different screening process, but again, it is tailored towards the patient. And medications which will assist with your phosphorus metabolism are phosphate binders like sevelamer. And as I mentioned, you can have knowledge of several medications, but if it's not available, if it's too expensive and we can't get it, then you can't get it. But sevelamer is one of the medications that assists with binding the phosphate, but we also know that given with meals, calcium supplements also serve as dietary phosphate binders. So patients are all may be told to take the calcium at different times with meals or without a meal and so on, and that is again, something that is patient-based. So because your person dialyzing next to you is taking theirs 2 in the morning with food and 1 in the afternoon, and you are being told to take through it doesn't mean that you now switch to theirs because you like their regime. It is tailored towards it. Everybody's medication is tailored to them. The kidneys are responsible, as I mentioned, for the excretion of drugs. So we don't have to give you any medication for this, but what it does mean is that we adjust the dose of some of your medications for those that are excreted through the kidneys, because if it's excreted through the kidneys and the kidneys are not working as well as they should, you might get a buildup of that particular drug in the body, and it may then cause more harmful effects because you've got too much buildup at the time. So we may adjust your dose, especially for things like antibiotics. People will know a simple one that are essentially simple, but medications that are frequently prescribed, like your augmentin, which for patients without kidney disease may be prescribed as a twice daily or thrice daily, 3 times a day medication. For the renal patients, we might give it to you once a day. Or we may say, well, you're using this medication, but we're going to give it to you intravenously after your dialysis session. That way we know it's in there until your next dialysis session. You get the dialysis, and then we give it again, and we know then it's in the body again. So that's the sort of the dose adjustments that we need to make for patients who have renal impairment. And for those not yet on dialysis, sometimes you actually have to do a calculation and work out just how much of the medication you need to get. Medications which may be on your regular list, but are not necessarily directly related to kidney function. So again, for patients who are not yet on dialysis, who have experienced a buildup of urea, and urea causes a lot of itching and discomfort, you may be prescribed antihistamines, and this will help to settle those symptoms sometimes. But patients who are on this dialysis and receiving adequate dialysis probably will not have these sort of symptoms continuing. But the buildup of urea can cause itching. Patients may be prescribed multivitamins, and for reasons that we mentioned fairly at the beginning of the presentation, when I talked about not everyone is able to exercise, not everyone has the strength or the wherewithal to eat as they should, and the diet for renal patients is fairly restrictive and quite difficult. So some patients may need to have just a general multivitamin to replace the nutrients that they are not getting from their diet, and just to help to boost all those functions that I told you that the kidney is responsible for. And because Many patients are on oral supplements to boost their hemoglobin. Many patients complain of constipation. And it's not only the patients who are on iron supplements that will complain of constipation, but generally for a renal diet, we advise you to reduce your water intake. And as you can imagine, if you have less water going through the bowel, then it's going to be, the stools are going to be harder, and it's that much more difficult to get soft and comfortable stools. So we may have to prescribe laxatives as well. Several names for these. Some of them may be something like a docusate sodium. It may be in a powdered form, like your benefibers and your consul orange. Although for some patients, because they need to take more water to get these to work, excuse me, they may not find as much relief as if they took something like the docusate sodium, which is in a tablet form. And again, other medications which we might give is the other liquid medications, which you have to, if you're given a liquid to assist with laxative, you have to remember that it is a liquid and you need to measure, take that then out of your daily dietary allowance of liquids. Many patients come and bring little bottles and say, can I take this? Or call and say, oh, I want to start taking this herb. Is it safe? And general rule is that any herb containing something called aristotrolic acid is not advised to take if you have any renal impairment. And so you'd have to be specific about that. And it's found in several Chinese herbs, so you need to take that. But really the general rule is to discuss herbal medications with your doctor as well. And you probably will need to look for the specific thing that you are having. And this applies even more so for patients who are on warfarin, because warfarin interacts with so many medications, and the so many things interact with warfarin, I should say, because you remember we need to keep that INR at a certain level. So if you're going to take extra herbs, then we need to know so we can watch that INR to make sure that it is not being adversely affected, and we're going much higher than we need to or much lower than we should be. Hopefully everyone is familiar with this, or something that looks like this. This is a pill box, labeled Sunday for the whole week, Sunday to Saturday. And this one holds medications for sort of morning, afternoon, and evening. There's actually medication that there's actually some of these medication holders that have a fourth tray, which I like because oftentimes it can be a four times a day medication dosing that you need. But this is good. It's just this, I like this because it serves as a reminder, and you know if you can know if you've taken it, you know what you've missed, and we can continue on this path. So in summary, just a few tips or a few things I just want to make sure. It's just that you ask questions when you're unsure about your medication. And in the dialysis unit, you know, it's a group, it's a multidisciplinary setting. It's a group setting. So you can ask your nurses, you can ask the doctors on the unit, you can ask the doctors in your clinic, you can ask the pharmacist who's dispensing you the medication. Everybody will have advice for you. And if they don't know, they should be able to say, well, we'll check and get back to you, so that you're always on top of any queries you have with your medication. These are things that you're taking usually every day, and you should be comfortable and understanding why it is that you're being given these things. And take the medication as prescribed. It is of no benefit to you if you're not taking the medications as prescribed and still having issues. So, and if you stop the medications, then we need to know, because we need to know, well, you're managing quite fine on whatever it is, so that we're all up to date. And this is why, you know, you need to take note when doses change, and you need to inform everybody of the changes. Certainly in our setting, and I'm sure for other patients who have renal issues, that you're being seen sometimes by more than one disciplinary. So you might be being seen in the cardiology clinic, might be seen in the ENT clinic, it might be being seen in the nephrology clinic, and people are chopping and changing medications. And it is you need to take a note of when these doses change so that you know what it is that you're currently taking. Um, it then confuses us when we are making adjustments for something that has already been adjusted. If you're following, for example, only this week I got a note back from a cardiology clinic, and it said that the patient, one of their antihypertensive medication was discontinued, and that they were supposed to increase another blood pressure medication. When I look back at the patient's note, on my end, they were already on the higher dose of the antihypertensive, and the other medication had already been discontinued. So, but because they're being seen perhaps in different clinics, and as you know, by different doctors, it may have not been clear to that person, or what may have happened is that the patient never made those changes and still went back to clinic and said, well, this is what I'm taking. And that's where some confusion occurs. So I've mentioned about that. And as I said, be honest about your health provider about what you're taking. So if you are anemic and we think you're taking iron tablets 3 times a day, then we're trying to figure out, well, why are you so resistant to the iron? But if you know you're not taking the iron, then you need to say, well, I'm not taking the iron, so we can work out why and see if we can get a different formulation or try it in a different form. Is it that you need it intravenously? Is it that, we need to try a different brand? Things like that. But you need to, if you don't let us know, then you're not involved in the process, and we can't really assist. I have been talking your ears off, so do you have any questions?